Good evening, Ramakrishna sir. I think it's time.
Good evening, sir. Good evening, Dr. Bala, sir. I'm a little late, this being Monday, so I had to run to get this. Sorry for it.
Oh, no. Ambedkar sir is waiting, sir. Vijay Shah, you can stop sharing for a few minutes, then you can start. I think Ramakrishna sir, you
Can
can
we wait for just a minute or two, sir? That Singarwell, sir. We'll wait for 1 or 2 minutes, then we'll start. Okay, sir?
Okay, sir.
Professor Singarwell.
Okay, sure, sir. Ramakrishna sir, I think you can start, sir.
Oh.
Very fast. Hi guys. Well,
చెప్పు మీటింగ్ లో నేషనల్ లెవెల్లో మీ కేసు డిస్కస్ చేస్తారు. So, shall we start, sir? Good evening, all. Welcome, Professor Singarwelu, sir, teacher of teachers, Professor Amdekar, Dr. Bala, sir, and all the dignitaries on the dais and off the dais. And it's a privilege, great privilege to have Professor Amdekar in this platform. And all of us will be immensely benefited. I'm happy, I'm proud that I am at least physically on the flyer by the side of Amdekar. It's a great privilege for me. And it is great privilege for Dr. Viraj also to present case to Professor Amdekar. And everyone knows about Professor Amdekar. That's why in the flyer, I did not mention about him. It is something like asking for a Bharat Ratna to Netaji Subhash Chandra Bose. Netaji Subhash Chandra Bose doesn't require any Bharat Ratna or anything. In the same way, Professor Amdekar doesn't require any prefix and suffix in the flyer. Right, sir? He's for the postgraduates who joined recently 1 or 2 months back. He's a great clinician, excellent pediatrician, great human being, and very humble and very simple. And he strives for the imparting of clinical knowledge to all of us, even though he is in mid-80s, close to Professor Amdekar. And I welcome Professor Singarwelu to talk a few words of message to all of us.
Thank you, National Convener, Professor Ramakrishna Paramakrishna sir. Because this session is mainly meant for case file for postgraduates, and every time a great teachers are taking part. Today is very unique that our Professor Ambedkar sir, past national president, I need not talk much about him because I can tell you all know that he is a great academician. But I can say, because as a president elect, I can know about his administrative capacity, how much he was committed to our IAP, about the growth of IAP, how much he has contributed. Definitely, it means a lot, sir. Apart from his academic, how academic and administration and association can be taken together. We have to learn from Ambedkar, sir. He is a mentor for not only for students and people like me, for administration and other things also. So our SBS sir said, I have President Neelam has joined. Sorry, ma'am, time has gone because we have started, waited for a few minutes.
No, no,
Now
no, no.
over
I
to,
heard you, sir. I was there with the other phone. So
okay,
I
thank
heard
you.
you. You speak,
So
I
over
speak,
to you
one and the
and
same.
happy learning to all and over to Rameshwar sir to call president.
Right. Good evening, our national president, Dr. Neela Mohan. She has just joined, and I request you, ma'am, to give your words of wisdom.
No, sir. I would ditto Dr. Singarabelu. I heard him say, I mean, not only his academic skills, but I still know only the academic skills, though he was talking about administrative skills. I would apologize maybe because I must have been too young in IAP not to have vision that. But I knew Dr. Arya used to talk a lot about him, and he was a good friend of Dr. RN and Arya, and that's how I was connected to him. And to me, he was none other than an academic person because every conference I would remember in CMEs, there would be a great line for his session, and we would all hope our talk is just before or after him so that we get the audience. But once it happened, but unfortunately, my talk was preceding, but when he joined, the audience were much more. So, so he's famous for being the you know, be honey which attracts all the IAPians. And I'm looking forward for the class because it was a delight last time to hear him with Bala on that interesting case where he spoke with great humility. And it was a lot of learning on PUI. It was thoroughly. And I'm looking forward for this case too. Thank you.
Thank you, ma'am. Thanks for your words of wisdom. Now I invite Professor Abdekar to take the center stage. And Dr. Viraz, please share the screen. I am sure that you will excel in presentation. Wish you all the best. Be confident and assertive in presentation. Professor
Thank you,
Abdekar.
sir.
Right, sir. Make it right. Please make it. Yes, yes. Proceed.
Uh, I may proceed, sir?
Yes, yes.
Yes, yes, please go ahead.
Yes, sir. Good evening to all my senior teachers. I will try my best to present the case with the best of my abilities. The case I'm going to present today is a case of fever with hepatosplenomegaly. Um, a
Just 1
10-year.
minute. Dr. Viraj, just 1 minute. Sorry to interrupt. I thank Dr. Deepti Pujari for facilitating presentation by Dr. Viraj to Dr. Ambedkar. Right? Proceed.
Yes, sir.
I think,
So,
Viraj, you go ahead.
yes, sir. Um, a 10-month-old male child is a resident of Pandurang Nagar in Sutardara, Pune, who is Hindu by religion, first by birth order, of a non-consanguineous marriage, is brought to Dinanath Mangeshwar Hospital by parents with complaints of fever since 3 weeks. generalized swelling over the abdomen, over the body and abdominal distension since 2 weeks, yellowish discoloration of eyes since 2 weeks. Informant, being the mother, is educated as well as reliable. Uh, History of present illness. Child was relatively all right 3 weeks back when he started having fever, which was intermittent, high grade in nature, associated with chills and rigors. 2 to 3 fever spikes per day were documented, relieved on oral medications temporarily, associated with generalized weakness and body pain, but not associated with any rash. Even when afebrile mother noticed that child preferred to sleep and had reduced activity. Few days after the onset of fever, she noticed that the child felt pale and had yellowish discoloration of eyes, which was gradual in onset and did not progress to other parts of the body. The above symptoms were associated with decreased appetite, lethargy, intermittent vomiting episodes 2 to 3 times per day, which was non-projectile, non-bilious in nature, without any blood, associated with nausea and associated with some nausea uh, and some dull aching pain in the abdomen, which were relieved on medications temporarily. He started having swelling around his eyes and both the feet, which was gradual in onset and progressed to the ankles and over a few days increased up to both the knees. His swelling became more prominent over the next few days with distension of the abdomen, which was gradually progressive and associated with swelling in his pubic and groin region, with pain in abdomen and also tightening of clothes. He also developed cough since the last 5 to 7 days, which was gradual in onset, non-productive, increased over the course, but not associated with difficulty in breathing or chest pain. So, my negative history. Uh, the child had a history of travel to Latur and stay outside Pune for 1 week prior to the onset of fever, where he had also consumed outside food. There was no history of itching or scratch marks over the abdomen as per the mother. There was no history suggestive of pale stools or high colored urine. There was no history suggestive of recent or past blood transfusion, indigenous or herbal medicine intake, or any consumption of raw milk or dairy product. There were no history of loose stools or blood in stools. Uh, there were no history of decreased urine frequency. Um, There was no history suggestive of any bruising over the skin, no history of previous heart disease or chest pain or difficulty in breathing, no history of altered behavior or disturbed sleep, no history of any significant weight loss or contact of a known case of tuberculosis was informed. There was no history of night sweats or any bone pain. There was no history of abnormal body movements or altered sleep cycle or lack of coordination while doing activities. Also, there were no history suggestive of any hair loss. Treatment history.
Just a minute.
Yes,
Professor
sir.
Amdekar, you want to discuss the history of
I
present
think
illness?
Viraj will go back to your first slide.
Yes, sir.
Yeah, even before that one.
Yes, sir.
Go ahead further. Next one. Yeah, now, no, one before this. You're putting up now, just now. Yeah, stay with that.
Yes, sir.
Now, uh, the most important point to start with your history is to tell me whether he was absolutely well. Now, you
Yes,
said he
sir.
was absolutely well, right?
Yes, sir. He's
So, how did
relatively
you
well.
confirm that he was absolutely well? Many times the parents would say, okay, he was well. How did you convince yourself that he was really well? By that I mean he was fairly nourished, he was happy, healthy, active, there was no problem at all. How did you convince yourself that?
Sir, the child used to visit school regularly. He used to play with his friends. had a normal day-to-day routine associated. Fairly, he used to gain weight as well adequately, and yes, sir, he was having normal eating pattern, and yes, sir, there was no associated uh, history of admission prior to this also.
Okay. So you said that apparently he was a healthy and normal child, right?
Yes, sir.
Yeah. Now, such a healthy child came to you with fever since 3 weeks, but the fever was the only symptom for first week. Am I right?
Yes, sir.
Yeah. So now, if you were a pediatrician at that time, when he came to you with fever for just 1 week and there were no other symptoms, how would you consider to approach this situation? Would you not like to know more about fever? So the next slide probably tells you that. Can we have the next slide, please?
Yes,
Yes.
sir.
So now what do you make out of these details? You have given fair good details of it. So what do you infer out of this?
So, sir, the child had high-grade fevers, which was intermittent. So, presume that there were periods of afebrile period between the spikes, and it used to get relieved on oral medications fairly as per the mother. Along with that, the child had some weakness and body pain. So, based on the given details by the mother, um, uh, the I would presume that the child has an infection. Uh, if there is only fever associated with it, then I would like to associate this history with and fever since less than only if there is only less than 7 day of fever, then I would like to associate this history with something like dengue or a tropical illness like chikungunya or uh, yes, sir,
Good.
leptospirosis or yes, sir.
Yeah. So whereas what I wanted to say is that when you look at this child's fever for first 1 week without any other symptom, I want you to convince me that this is only infection and not any non-infective inflammation. That's your first difference to make out. Can you tell me why you did call it this as an infection and why not non-infective inflammatory disorder? Because so
Uh,
far we have nothing to go by except fever.
yes, sir. Sir, and most of the times infections are associated with chills and rigors. Non-infective disorders usually did not have high-grade fever, and they are not usually associated with chills and rigors. Um, Apart from that, the child had some generalized weakness which was sudden in onset, and again, he had body pain as well. Um, yes, sir.
Okay, fine. I
And he
think
was a
I
well
want
child.
to.
He was a relatively well child according to the mother. So there was no history prior to this also. So sudden onset, high grade fever, I would say that it mostly looks like an infective pathology.
I want you to take a note that chill and rigor doesn't push us to any particular inference because chill means a peripheral vasoconstriction that a patient feels little cold, and it only means that the nature is trying to push up body temperature. But the rigors mean that the nature wants the body temperature to get even higher, and therefore the chill is a peripheral vasoconstriction that conserves heat.
Yes, sir.
And rigors is the need for body to shoot up very high fever with muscle contractions and therefore more production of heat. The first one,
Yes.
chill, is just the conservation of heat, and the second is that. Now, the point is this could happen with anything. It does not mean that it's only infection. It certainly doesn't mean it's malaria or whatever. So all that we note by that the only point that I feel, yes, you are right, that high fever persists. So I want to know whether the pattern of fever has been persistent over the first week. You said 2 to 3 times high fever spikes. So is the rhythm of fever maintained the same way?
No, sir. The fever pattern initially was 2 to 3 fever spikes per day. With intermittent afebrile period was there. Some days the mothers did say that a few days the child was afebrile in between. Mostly for 3 4 days, the mothers did say that the child had periods of the afebrile period.
Okay, so do you still want to push infection as the first possibility? Because he has high fever with 2 3 spikes per
Yes,
day, and then he becomes febrile in between to
yes, sir.
get fever again. Now, is this the way a typical bacterial infection behaves, or a typical viral infection behaves, or it's something other than a common bacterial or viral infection? What is your take on that?
Sir, most of the bacterial infections and viral infections, they will have a consistent fever pattern. In most of the cases, there won't be a brief uh, afebrile period of so many days in between. Either if there is any non-infective pathology, as you said, then there may be certain periods of afebrile period. Very rarely in certain bacterial infections and or certain protozoal infections there may be periods of afebrile period in between. Uh, so, sir,
Very good. I think you are right. And therefore, this is not the usual way a common bacterial or viral infection proceeds. Now, do you think because this is fever off and on, can you consider this as tuberculosis?
um,
It is fever off and on, right? In between a febrile, back again with fever.
yes, sir. As much as I have, sir, as much as I have experience of seeing tuberculosis patients, most of them they do have fever every day. Uh, with breaks, 3 to 4 days of afebrile period, I have rarely seen with tuberculosis patients.
Good. So in TB, that off and on is invariably a low-grade fever off and on.
Yes, sir.
If TB presents with high fever, which is well known, it is an immune response to a TB bacillus, and therefore often the fever is not off and on, fever is more continuous, and then you are looking for some localization coming up, like an acute pleural effusion, for example. So this is not tuberculosis either. So
Yes.
would you now say that this is a non-infective inflammation, or would you still push some other rarer forms, or I would say uncommon forms of infections?
Sir, look, I can consider that there are some other rare forms of bacterial infections, but they are very rare. Relapsing fever is one of the causes that I can remember in bacterial, and in I think protozoal infections, I think malaria is the only thing that I can look up. In cases of infective, if I have to look, if there are such 3 to 4 days of afebrile period.
And so,
Otherwise,
in principle, it doesn't fit in easily any infection that we know of. Okay. Well,
yes,
medicine is uncertain, but in uncertain medicine, we want to be as close to certain as possible, knowing
yes,
the
sir.
limitation, of course. So, if you think that this is non-infective inflammation, then what kind of non-infective inflammation are you looking at? Are you looking at some autoimmune disorders? Are you looking at some malignancy coming up? What's your take on that?
Um, Sir, high-grade fever spikes, maybe malignancy in case of leukemia, it's a possibility, but high-grade fever spikes is still does not fit with leukemia or lymphoma either. Apart from that, autoimmune hepatitis, they do present with fever spikes, but still the nature of fever spikes, I'm not very sure about. Um, Apart from that, collagen vascular disorders, they do have high-grade fever spikes. So uh, maybe that non-infective pathology you can consider.
Very good. So at this point of time, we have started looking at a probable non-infective inflammation. At this stage, we are not sure where we are heading to, but we almost have felt that infection is not totally unlikely, but much less likely. Right? Now
Yes.
comes the second symptom. Now, is the pallor and jaundice came together?
Um, the actually mother only noticed jaundice, but she felt that the child was basically unwell, sir. So she felt that the child looked much paler than what she had seen before. Maybe it is because of the jaundice as well. Uh, so yes, sir. I
So, so there was no pallor noticed by the mother, right?
yes, sir. As such, she
So
did
the
not
mother,
feel that the child was
yeah,
anemic as such.
fine. So mother noticed jaundice. Now,
Yes.
jaundice has come up on day 8 of fever. What's
Yes, sir.
your comment on that? Why has the jaundice come up so late in the course of illness?
Um,
Give a try. You are doing very well. You are doing very well. Okay. So
maybe it
give a
is
try.
yes, sir. Maybe the progress is a bit subacute, not very acute or a fulminant course.
Hmm.
So maybe that is one of the reason. Um,
Good. Very
Also,
good. So,
yes.
yeah, come on.
Um,
So, so Viraj, probably what I wanted to stress was that your first thought comes that this is not a primary liver disease. Okay, it has come up, jaundice has come up much later in the course of events, and therefore, first impression is whether this has been an extra hepatic disorder with secondary involvement. But do you think this could be hemolytic anemia and jaundice?
um,
Because you said there was no
yes, sir.
high colored urine, right?
Yes, sir.
So if there
Um,
was no high colored urine, don't you think that this must have been an indirect bilirubinemia?
um, Sir, along with fever, um, it is very yes. There is always a possibility of a hemolytic anemia presenting, especially some traits. Uh, but along with fever, and this was jaundice was noticed for the very first time by the mother. Uh, I think it would be less likely to point out towards a hemolytic cause.
So do you think it's a hepatic parenchymal involvement, hepatocellular jaundice, or maybe a hepatobiliary jaundice? That's what you think?
Uh, yes, sir. My primary would be the hepatocellular involvement. I would feel that
Okay,
that would be
all
much
right.
more
But
likely.
now why is your hepatocellular jaundice has no high colored urine? Normally, the first difference in jaundice evaluation is whether the urine is high colored or not. And the second is if it's high colored, then what would be the stool color like? But you are sure that this was not a high colored urine. Is that so?
Yes, sir.
Or you're not very sure about that?
Sir, based on the history that the mother said that the child was not passing any dark urine or a high colored urine. So I would say that.
Okay, because see, the mother which notices jaundice in the eye, yellowishness, is
Yes, sir.
unlikely to miss a high-colored urine. Okay, but
Yes,
we will go by what you say. But if you are sure there was no high-colored urine at all, and therefore a jaundice noticed by the mother is mostly significant hepatocellular or a biliary disease, because in indirect bilirubin coming up, the jaundice is mild and often parents would notice pallor more than icterus. So
yes, sir.
we are not sure about what's happening in this child. Okay. And therefore, what would be your best bet? Do you think it's a hepatocellular or a hepatobiliary problem, even when there is no high colored urine?
Uh, yes, sir. I feel that might be a hepatobiliary or a hepatocellular
Okay, all right.
involvement
But
more than.
point is, point is that if that is so, then you must get back to the mother and convince and confirm that there is no high colored urine, or then the mother says, yes, it is high colored. So,
Yes, sir.
point that we are learning is that at each time when we analyze history, we want to be sure that what is reported by the mother is exactly what we have understood, and if there is any discrepancy, then we must again clarify whether mother hasn't been able to pick up rightly. Her statements are a little ambiguous, and I think we'll go by that. So let's decide, because you seem to be saying that it's a hepatocytobiliary disorder. I would favor that only by one reason, that any indirect bilirubin rarely manifests by mother noticing it even before the pallor is noticed, by and large. Yes, there are enzyme deficiencies, etc., where jaundice will come without pallor, but they are not sick children. So, for all practical purposes, we may confirm whether the urine was high colored or not, but we might not fit in a normal color urine with a hepatobiliary or a hepatocyte disorder. That's the point. Let's go ahead then. Then what happened thereafter? A generalized swelling came up, right?
Yes, sir.
Now, how do you look at the generalized swelling coming up after that so-called jaundice, and that too after about a week or more of fever? What must have happened for a child to get suddenly a generalized swelling?
Uh, yes, sir. A typical history of fever along with jaundice, and then simultaneously having some amount of swelling, generalized swelling over the body. I would think that the synthetic function of the liver might be affected. So, because of that, that there might be decreased production of albumin and decreased and that leading to swelling over the body.
So you think it's a severe hypoalbuminemia, right?
Yes, sir. Uh,
Okay. Uh, so how are you sure it's not a renal disorder?
um,
I know nephrotic syndrome typically present with generalized edema. Do you think this has some problem causing fever has also caused a renal disease and
um,
also hepatic disease? Both are likely. You are so far sure about a hepatic problem, but tell me, because there could be multiple organs involved in diseases, to convince me that it's not a renal disorder.
yes, sir. There was no associated decrease in the urine frequency. Uh, there was no oliguria as such. So, a renal disease, I would say, just on the basis of that, looks less likely.
Fairly all right, because what you're trying to say is that nephrotic syndrome may come with normal urine output because it's just a glomerular epithelial disease, but this is not going to be that because the healthy child suddenly gets that is what typical nephrotic syndrome is. But nephrotic syndrome is also a variety of nephritis. So
Yes,
we
sir.
try to differentiate the two, epithelial from endothelial, but they all form a group of nephritis, and that is typically an oliguria, hematuria, etc. So I agree that this is unlikely a renal disorder, and so very likely it's that. Could it be anything else like, uh, is there a possibility of suddenly a lymphedema coming up because a disease we don't know what we are heading at? Could there be lymphatic obstruction coming and then you have an edema? Uh, you are right to think about the jaundice and then about the generalized edema. So you pushed hypoalbuminemia. But I want you to debate whether it could be also a lymphatic obstruction. What is your take on that? Because
Sir,
you are doing so, I'm going to ask you a bit of odd questions. So give a good thought. It not necessarily you are right. Even I am often wrong. Don't worry about it.
yes, sir.
So just try to tell me, uh, could it be a lymphatic obstruction?
I
Sir,
request just a minute, Viras.
yes,
I
sir.
request all the postgraduate to post their answers for the questions posed by Dr. Abdekar. Go ahead, Dr. Viras.
Um,
Very good. See, you're so right that if there is a disseminated generalized edema, then it's like the less likely that it is any lymphatic obstruction, right? And therefore, we are reasonably sure. Uh, and you had already said that you had a reasonably healthy child, so it is not any secondary malnutrition coming up, and therefore, very likely it's a manifestation of a hypoalbuminemia. Can you make the slide full screen?
yes, sir.
We have got onto again a small screen. Make it
Yes,
a
sir.
full screen.
Yes, sir.
Yeah, that's fine. And therefore, at the end of that, he's developing a cough as well. Now that's funny, isn't it? We
Yes, sir.
we started with fever. We said we have no idea. Fever is the only symptom. Then we got on to jaundice, and then you been feeling that it's hepatocellular, though I want you to check with the mother and the urine color as well. But let's go ahead just now with whatever you are trying to convince me. And then a generalized edema, which you consider it's a hepatic disease, so severe hypoalbuminemia. And now the cough comes. Now, how do you associate all these? Why should the cough come in a discussion that we are on some inflammatory disorder, some hepatocellular affection, and now you are getting generalized edema to severe hypoalbuminemia, and now a cough. What do you make out of this cough? You said since last 5, 7 days, which was gradual in onset, okay, not productive, and there's been gradually increasing, but not associated with any difficulty in breathing or chest pain. What do you make out of this cough?
Uh, Sir, what I could make out was that any inflammation or infection of the liver uh, might lead to a reactive pleurisy or a pleural effusion. Maybe one of that cause can be there, or it is a completely separate issue than what we are dealing with. The maybe the fever, the jaundice, and the generalized swelling, they are completely separate from a new onset cough that the child has acquired. So there can be both the possibilities which I thought that the mother was trying to say.
Whenever you have a cough, my first question is, how severe is the cough? Okay. If the cough is severe, I'm looking at the airway. And if the cough is not severe, then it could be a distal airway, or it could be parenchymal, or even an interstitial lung.
Yes, sir.
So that's the first important thing. But this cough seems to be increasing. Okay,
Yes, sir.
even over 5 to 7 days, you say it's increasing.
Yes,
What
sir.
does increasing cough mean to you now? And you have added that he has no difficulty in breathing. So
Yes, sir.
which cough of this nature is increasing, but without chest pain or without breathlessness? So again, you need to check on all this, because
Yes.
if this was, say, a pulmonary edema because of maybe myocardial involvement or whatever, one could have got breathlessness in predominance. That
Yes,
is
sir.
not happening. So
No, sir.
it's just a cough. So possibly it may not have been a severe cough. And then the question is, what is it due to? And we are not very clear at this point of time whether it could be still a developing pulmonary edema because of multiple factors, or also involvement of maybe myocardium. But we are not sure about that because there is no breathlessness to support it.
Yes, sir.
So we leave it that for a while because we have no idea how to fit in a cough like this. And you gave a good negative history. Can you put that negative history on?
Yes, sir.
Yeah. And the only positive history of some travel, right?
Yes,
What do
sir.
you infer out of that travel? Do you think the travel is related to what's happening in this child?
Uh, Sir, maybe the child had traveled to an endemic area, and maybe he might have picked up uh, a tropical illness out of there. Uh, so that's why I mentioned that it was significant that the child had traveled to a far off place, and yes, sir. So that is the only point I thought that was significance.
Okay, but I'm sure that Pune and few days outside Pune may not make a much difference as far as the travel is concerned. Okay, but I see your point that you want to pick up, and you said that it could be a tropical, but even in Pune, it could be a tropical
Tropical illnesses.
infection.
Yes,
So
sir.
it doesn't lead us to anywhere, and there is nothing else. You are all negative history, and even in the next slide, your negative history is not contributory. Like you have
Yes, sir.
given all kinds of explanation for those negative histories. Now, do you have anything to support on a personal history or any other part of history? Then we will
Uh,
discuss what could be our impression only on history.
yes,
So,
sir.
do you have any more information about past history, dietic history, family
Uh,
history?
Yes, sir. I have some treatment history. I'll proceed towards the past and personal history as well. There is no positive finding as such in the past and personal history. The child,
Okay.
however, was admitted in a private hospital at the place where he had traveled for a period of 10 days in view of the above complaints. And he had received some medications for the same, which improved his overall condition temporarily. The initial laboratory investigations which were done in the hospital were explained to the parents as some form of infection in the liver and swelling over the liver, the details of which are not known exactly. Sonography was done. It revealed some fluid accumulation in the abdomen as per the mother, uh, and some swelling over the liver. Mother recalled that some quantity of fluid was also removed from the abdomen for testing purposes. Um,
Okay. So,
and
yes, go ahead further.
and then he was referred to the tertiary level hospital in view of above complaints and for further management. Yes, sir. And pretty much then we started our evaluation regarding him. And
Fine. So far what we have gathered is it's likely to be non-infective inflammation, though we are not sure whether there is still some infection. Okay, because he has been given some medication that may be the cause, but that is not very certain to discuss. But then thereafter, definitely there is some hepatocyte involvement, and thereafter there is a jaundice coming up. Do you think this jaundice is swelling coming up? Do you think this swelling could be a capillary leak? And then
Uh,
suddenly they get swelling. Okay. Could it be a capillary leak itself? Now we are
yes, sir.
complicating the issue. Yes.
There's a possibility of a capillary leak as well, sir. In cases of infectious diseases, yes, there is a possibility.
So by and large, if it's a capillary leak and he has got such a massive edema, then surely he is going to be very sick, almost tachycardic. Okay. And if that has not happened, then possibly we are not dealing with a capillary leak. Again, a generalized edema is little unusual, though small infant might suddenly present with a weight gain and due to edema, but otherwise, no. So we will stay with that. Now, having said that, uh, anatomy seems to be the liver. Okay, pathology seems to be inflammation. Now, etiology. Now, can you guess now, at the end of all that, what kind of etiological diagnosis we could think about in this child?
Sir, sir, in the cases of purely, if I have to say, on the basis of non-infective etiology for the liver, which has caused his inflammation, um, then I would like to consider a case of autoimmune hepatitis in my mind. Um, Although the presentation does not fit all does not check all the boxes. Apart from that, I would still try to consider malignancy in my differential diagnosis for the child. Um, yes, sir.
Okay. Do you think this could be leptospira? You have fever, high fever, and then at the end of 5, 7 days, he comes out with a liver disease. Do you think it's a leptospira?
Um, Sir, I think I would need more information for me to at least say comment on leptospirosis. Um, Obviously, uh, there is a possibility, but I think leptospira, um, there, if the fever has persisted for so many days, and most of the common presentation of leptospira is anicteric, with icterus being very rare, and if there is icterus, there is always involvement of a multi-system kind of pathology in the case of leptospirosis. So, uh, if infectious disease in case of infectious disease, if the fever has gone on for 3 weeks um, uh, with such a finding, such a picture, then even leptospirosis I would like to keep down.
Right. So I think the major reason for it being not likely is that there have been periods of febrile in between those high spikes of fever, and that is unlikely to happen. But even leptospira with further liver involvement is an immune mechanism, and therefore, uh, I said, could it be infection-induced immune? Same thing would be done for rickettsia, for example. You have no reason to suspect rickettsia and also no brucellosis or any such disorder which go on for a long time without much other organ involvement. So then, is your diagnosis provisional on the history is an autoimmune hepatitis? Is that what you are trying to say?
Yes, sir. If you consider just my outlook, I would still want to keep infectious disease above, because the child was hospitalized also during those periods of afebrile period. Maybe the child has received some amount of antipyretic, uh, uh, which may lead to that impression that the child was afebrile. So I would still like to keep my infectious disease in the probable diagnosis above, and then probably go towards autoimmune hepatitis or any malignancy.
Okay. But generally, when you are treating infection, before the antibiotic starts working, mere paracetamol does not bring down the fever and remain febrile for some time. After
Yes,
all,
sir.
paracetamol works only if the center higher up decides not to continue with high fever. So it
Yes.
is very unlikely that that febrile period is the effect of paracetamol, and therefore we will not get into that, but that's unlikely. Lastly, do you think it's some toxic problem that has produced maybe some toxin induced such disorder? Because you have infection of the liver, which you said is less likely here. Could it be hepatitis B or C coming up acutely? What's your take on that? Most of the times, hepatitis B or C are chronic disorders in pediatric practice, but even acute disorders are known. So, do you think we can consider hepatitis B or C?
For hepatitis B, the incubation period has to be a little higher. And also, there was no history of any uh, parenteral uh, drug intake or any history of blood transfusion in the near history as well, in the near future, in the near past as well. So, hepatitis B also seems
Yeah, you're
acute
right. But
hepatitis.
point is that 5 to 10% of these B or C may present acutely, but the story almost starts with jaundice very early in the course of the disease, and therefore that is not possible, and therefore we are left with that. Just convince me that it is not a malignancy of any kind.
Um, Sir, the child did not have any weight loss or um, um, even if we consider hematological malignancies, the child may have some bone pain or some amount of weight loss might be there. So, in malignancy, I have to consider in case of non-infective pathology, but still I would keep it down, sir.
Fine. So malignancy is unlikely,
Night
and
sweats were not there.
therefore, yes. So we are left with that. Now, last question is, could it be by any chance a Wilson's disease?
Uh, Sir, it can. Wilsons do present in that age group. So there may be some underlying disease of the liver, which probably very well can be Wilson, and it can be so that the child may have gotten an acute infection on top of it, so thus worsening the situation for the child. So I can keep Wilson's disease as an underlying cause in my differential diagnosis.
I think high fever is very unlikely just a Wilson's manifestation, and
Yes.
therefore, even though Wilsons have a very wide spectrum, but wide spectrum still involving the hepatocyte primarily. And here
Hmm.
is a child who starts showing hepatocyte dysfunction manifestation after about a week of fever. That's very unlikely to be a metabolic disorder. And therefore, just a rule that anybody who has been above 5 years of age, just keep in mind that it's not going to be Wilson's, but this is not likely to be Wilson's. So now your probable diagnosis stands at autoimmune hepatitis. Uh, with severe hypoalbuminemia and generalized edema, and we are not sure where the cough fits in all this, right? Uh, Now, before you show us the clinical examination, I know you know the examination findings, but knowing this history, would you guess what could have been your positive findings? Ignore what you know, okay? Because justify. Uh, I'll ask you a specific question. How sick is this child on examination you anticipate?
Um, Sir, with a child having high grade fever with so much generalized weakness as well, and a generalized edema, anasarca like picture. So I would presume that the child must be very sick, and um, also on examination, if I have to presume that what positive findings I could get. Um, so, sir, in terms of general head-to-toe examination, I might presume that uh, the child might have anasarca, probably a grade 2, grade 3 edematous, grade 4 edematous swelling. Um, Also, icterus, I might expect in general examination. Um, since the onset and the progress is so sudden, I might have look for signs suggestive of any acute liver failure, um, uh, uh, like, for example, um, loss of hair or over the scalp, alopecia, or in the case of uh, some form of rash over the upper part of the chest, um, in the form of spider nevi or palmar erythema. Um, Obviously, the ascites component is there. So since the generalized edema has progressed so rapidly as well, I might expect that the child has a tense ascites. Um, yes, sir. And
Okay, all right. Now just tell me that you expect a large liver,
um, yes, sir. Since I'm suspecting a
right?
hepatocellular pathology, I
Okay.
do.
Uh, how are you sure that you are likely to see ascites there? So do you think it's a portal hypertension?
Uh,
Because ascites in the liver disease is portal hypertension.
yes, sir.
Okay.
So,
So do you think this is likely to be portal hypertension?
yes, sir. I feel that since there is ascites as well, and uh, I expect hepatomegaly to be present as well. So, I do expect that the child may have some portal hypertension, some features of portal hypertension.
Uh, so now let's see what clinical examination you are going to say that. But I would not have definitely considered ascites primarily. Generalized edema is fine. And you said the generalized edema is due to hypoalbuminemia. Now, this child has no reason to suddenly develop an uh, portal hypertension unless there was a venous obstruction somewhere, like uh, venous obstruction, like a butt cherry coming up. But this is not a story of that kind of a situation. There were probably not ascites. A primary hypoalbuminemia does not cause ascites without portal hypertension. Therefore, you possibly said there could be portal hypertension and which means there would be a splenomegaly also. So
Yes, sir.
that looks a little less likely to me. But yes, we will know now on clinical examination. So let's see your findings.
Uh, Sir, do I have to, do I, uh, based on my history, do I say the case summary
Yeah.
or I directly move on to my findings?
Okay. Uh,
Sir,
Viraj, you have done very well, but when you give a provisional diagnosis, you don't give every possible etiology. You
yes,
have
sir.
to narrow it down to maybe two or three, but you cannot give me, it could be infections of all kinds, it could be a metabolic disorder, it could be leukemia, lymphoma, or it could be primary autoimmune. No, you have not left me to add any more possible cause of the hepatitis. So possibly bring your provisional diagnosis to maybe 2 or 3, which should be very similar looking in presentation and therefore are difficult to sort it out just by history so far. And
Yes.
therefore, we did say that leukemia is unlikely, lymphoma is unlikely, Wilson's is unlikely. We said that primary viral hepatitis is unlikely. Uh, Largely, a rickettsial disease would have come up with much acute sickness. Leptospira, we said yes, because maybe uh, jaundice has come up a little later, and that could happen in leptospira. Tropical infection is a vague term. Okay. Uh,
Yes.
in tropics, every infection occurs,
Yes,
not
sir.
necessarily just those tropical infections. So that's possibly not a specific etiological diagnosis, so we'll leave that. And liver abscess is out.
Yes, sir.
Why am I so sure it's not a liver abscess? Or let
Um,
me ask you, why did you put liver abscess? So the
um,
answer is liver abscess never causes jaundice. And
yes,
the
sir.
reason is to get the visible jaundice, you need almost 80 to 85% of hepatocytes involved. Then only you get icterus. Okay, and therefore, liver abscess usually is a localized disease, and however big it may be, if there are 20% hepatocytes working reasonably well, then you don't have anything. Even multiple liver abscesses, like in Brucella, for example,
Algebra.
have no jaundice because in between those hepatocytes to manage bilirubin metabolism. And therefore, we will remove liver abscess. Look, uh, I hope you don't know, if I'm sure you know the diagnosis, but in an examination, if you know the diagnosis of a rare disorder, then don't talk about it at all, because you
Yes,
may not be able to justify that, right? So
yes, sir.
many of this might go out, but anyway, let's see. The point that I was making is a summary should include 2 or 3 close possible provisional diagnosis, right? Let's see
Yes,
your
sir.
clinical
Agree.
findings.
Just 1 minute, Dr. Viraz. Just
Yes, sir.
hold back. I invite our national president, Dr. Neelam, because she's a gastroenterologist, Dr. Bala Subramanian, Dr. Varinder Singh, to give their inputs. After that, we'll go
Sure,
to the examination.
sure.
Dr. Neelam, Dr. Bala, Dr. Varinder.
After Bala, I'll speak.
Okay.
Okay, thank you, Neelam. Of course, there is very little to add after that brilliant discussion. A few comments, of course, which Sir has already made out. One comment, in fact, leptospirosis is out in the diagnosis if you have fever for 3 weeks. You
Yes,
must remember, leptospirosis is one infection which responds to any antibiotic. And anybody with 3 weeks fever would have received at least amoxicillin, even that would have taken care of leptospirosis. In this case, leptospirosis, as Sir said, like liver abscess, is not in the diagnostic possibility.
Yes, sir.
Again, on a similar note, rickettsial disease causing 3 weeks fever, unlikely. Malaria, I don't know how you can, even in severe falciparum malaria, you don't get a presentation
Yes.
like this. And by this time, diagnosis would have been made. So I think amongst all the infections, hepatitis, viral hepatitis, agreed, is probably only thing which would remain. In fact, interestingly, the whole world is now talking about hantavirus. Hantavirus is very similar to leptospirosis, as most causes something like a hepatorenal or renal and pulmonary syndrome. So it behaves like leptospirosis clinically. So it doesn't cause chronic illness like this. Amongst viral hepatitis, again, one thing is straight away out. Amongst all causes of viral hepatitis, I think hepatitis A is straight away ruled out. it doesn't cause this sort of chronic disorder, more than 3 weeks lingering. Very, very unlikely. B, today in 10-year-old, it's extremely rare. C, unless there is some transfusion of blood products administration, is not going to be high on the list. So I think viral hepatitis also looks very, very unlikely. Coming to metabolic disease, yes, Wilson's disease is notorious, comorbid. For example, a child with Wilson's disease may also have some other infection, but the liver disease might progress because of Wilson's. Malignancy, extremely unlikely with this sort of presentation. In addition to autoimmune disease and the inflammatory disorder, though it's a male child, I think one diagnosis I would have definitely considered is SLE. That can explain your autoimmune hemolytic anemia, your progressive liver cell failure, your edema, hepatorenal manifestations, even though a 10-year-old male having this looks far-fetched. Last is a drug-induced affair. For jaundice, many a time people go into give native medications. The primary disease like hepatitis A may be benign, but the drug-induced insult to the liver and kidneys and other organs may be disastrous, heavy metals, etc. Right? And of course, any drug, even the allopathic drugs, cephalosporins are notorious for causing this sort of drug-induced fever. Anticonvulsants can cause this sort of manifestations. These are my thoughts at this point of time. Thank you very much.
Bala, I'm happy that I came very close to what you have been saying. So I hope you're an examiner, then you would pass me.
No, sir, who am I? My God. That's not fair, sir.
Dr. Deelam.
Mute. See, I would have a probably little different lens. I think I would call this acute on a maybe an underlying chronic liver disease. That means there was an acute insulted which precipitated an underlying chronic liver disease. That would be my first thing. So I would keep in infections tuberculosis also, because quite common to see 3 weeks fever with ascites and things like this was sort of well, maybe one in infection. I will keep that. I wouldn't keep, like Bala said, assuming he would have got antibiotics. So it is less likely, but I have seen uh, 3 cases of brucellosis also, which presented like this. And so in history, I would want to know whether there was an exposure to an unpasteurized milk. Is the child drinking milk which was unboiled? And, whatever the creams, do they have cattle at home? So this is the history I would also like to take in that. I would definitely keep Wilson's and autoimmune hepatitis because, as I said, acute on underlying chronic. But I should also tend to have keeping leukemia also in my mind and not rule it out, because there is fever going on from what I missed the second slide because I was in the car where the connection was poor. But when he showed the summary, I still understand that fever is there for 3 weeks. So that is why I would, without obviously, we don't have any, I would still keep, leukemia also in that thing. So these would be mine. And definitely, if I keep enteric fever, I would keep a dual infection, either an enteric with hepatitis and HLH. That would be my possibility rather than a pure enteric. I would call it enteric and hepatitis with HLH. So this is how I would move.
Thank you, ma'am. Dr. Varinder, even though it's not your cup of tea.
And in
Dr.
such age, we don't keep CMV, EBV, Hep C, Hep B. I would not keep Hep B alone. I would not keep. So these will be the only one which precipitates along with an enteric, because that is the one which will cause the HLH.
Ma'am, I would like to know why it is not primary liver disease. I am not saying it is liver disease.
That is why I explained you with my opening statement that I would call it acute on chronic liver disease. The reason is, how do you explain 3 weeks of fever? He said there was fever with chills, rigor. So that's why I said I was in the car. The second slide only I missed, but his first slide was fever with chills and rigors. How can any patient with a liver disease have 3 weeks of fever? So it has to be some infection, whether it's an HLH, whether it's an enteric hepatitis, whether it was a UTI, something gets precipitated. And autoimmune is pretty notorious to have fever. To call it drug induced, I would be a little not with Bala in this, because it started with fever and chills and rigors and not. So therefore, uh, I would be a little skeptical to keep a drug induced unless there was a history of non allopathic medicine, because that is one couple of cases I see, that patients who start presenting with fever and all that stuff, and they would have had some Ayurvedic medicines, and they end up with a rapid deterioration with ascites and this type of a picture in them, and their infection is not really treated because they are using that ayurvedic, so they present. So I would not call it as a start on drug. If at all, I would be thinking in that.
Okay, thank you, ma'am. Now we will proceed. Viraj, go ahead.
Yes, sir. Yes, sir.
Just one question, that if we are sure this is a very healthy child, then would you not say that there is no chronic any problem till
Yeah,
the
so
child started with that? Because
yeah,
there has to be some note about not doing well. Then I would
correct.
have said acute on chronic. Am I right?
Correct. So that's where I want to, very good question, sir. So if I may be allowed to answer that, is that is what is sometimes we get this autoimmune diseases, acute diseases. Right now, as I speak to you, I have a child who started with a fever 5 weeks back. And then the fever was not obviously for continuous 5 weeks, was initial. And then she turned out to have jaundice, and she presented to me with jaundice and ascites. And her reports are she had Hep A and now with LKM positive autoimmune liver disease. So what I'm saying is something, and you beautifully said that the liver cells had to be damaged before you get jaundice. I would say the other way. I would say also that the patient with chronic diseases like fatty liver disease or whatever, you're moving very happily in life, and they, God has given us 70% or maybe 65% to extra liver. So if we sit on a 50, we are just left with very little reserve. So when there is an acute infection, it gets triggered off. So that's why I said tuberculosis. I would be very excited in infection to keep tuberculosis, because TB can present you very nicely with such fever and ascites with 3 weeks, and the way he described edema. And if it was not an underlying liver disease, his edema came a little more faster than I would have expected in a typical acute liver disease. It got triggered off pretty fast to me, unless he or she, whatever, was losing some protein anyway, because the child was pretty well otherwise. So I I accept what you're saying, but maybe being a specialist, we see that part of the diseases too.
Ma'am, would you think that hepatocellular damage will lead to puffiness of the face?
No, so that is why I said that usually it is theoretically, I don't know, my examiners used to teach me a lot that nephrotic starts from the eyes and this. So, therefore, I did keep Wilson's in this case. The reason I kept Wilson is one a case where you will have both liver and kidney involvement too. So you can have a little rapid decompensation because of the two. And puffiness of the face, and whether it starts with the legs or the face, it's not around the eyes. The way he described your student, he never said it was around the eyes. He said face, and he said legs, feet up till ankle. So that is giving me the impression that there is a significant hypoalbuminemia in this patient, and hypoalbuminemia is because of two reasons. We've been always studying that the half-life of albumin is 3 weeks. But we have seen in our practice that you see ascites even, in ultrasound or clinical, even in an acute hepatitis. So maybe children from India, we justified maybe they're malnourished or maybe. And if there was an acute or underlying liver disease, that would precipitate the portal hypertension more rapidly, and you would get much more. I mean, your student gave us a little hint when Dr. Ambedkar asked him, how would you imagine your child to be? And he said, I would have imagined my child to be with 10 societies. So the mind thinks what the eyes, the eye sees what the mind knows, whatever. So your student gave me an idea that it is quite tense ascites. Because of that, I thought I should keep tuberculosis and acute on chronic liver disease. And in infection, I said tuberculosis or enteric with hepatitis, with HLS in that field. Otherwise, I said this. And this acute on chronic could be even precipitated by a UTI. But what is very interesting is your student never told us what medicines he took, what antibiotics he took. So I think that history is also very important to me. What he took and all that I would want to know.
Dr. Varinder, do you think that tuberculosis should have caused such picture? Dr. Varinder Singh. Dr. Varinder?
Yes. Am I audible?
Yes, sir. Yes, sir. Yes, sir. Please proceed quickly.
In the meantime, your student can tell us about that history, what treatment he took. Did he
Yes,
take antibiotics or
Dr.
not
Vilas.
any
Yeah,
drugs?
yes, ma'am. Ma'am, the uh, mother said that the child has received some treatment for 10 days. So I'm assuming that the child received antibiotics in the history. But
And no,
on
no
the referral sheet,
no Ayurvedic, right?
according to the history, that the mother
Okay,
revealed
good.
that the child has not received any indigenous medications or any Ayurvedic medications or any alternative. Uh,
So therefore, I would still keep Wilson's autoimmune very much, because all infections would have normal infections, I wouldn't keep brucella to the typical one, but enteric also would go down in my list. I would keep these. Over to Varinder for tuberculosis.
Dr. Varinder Singh. Tuberculosis and the case scenario. Right.
Am I audible?
Yes,
Yes,
sir.
yes. Please. Proceed.
So, good evening, Dr. Ambedkar sir, sir, Jones Bush. What I would say is that while teaching, we sometimes break up cases in a very artificial way. So we keep on discussing the possibilities on bare limited facts, as we are doing right now. In my mind, till we have the examination finding, limiting down the diagnosis. So infection, yes, a possibility because strong people present of fever. It could be atypical presentation of disease or atypical infection. I will leave it at that. Not go into what is likely there are points for it. And we have been very well distributed by tuberculosis, jaundice coming first, and which makes it a little harder to understand. Jaundice is not so common to have a lymph node pressing on the quota. So that's not the usual presentation. We did not hear any police cases. Otherwise, if there was no jaundice, it would have been easier. Very retrograde, edema, everything would have been explained, and some degree of jaundice coming there. So this way it does not fit into the story, except that TB can present in which way it is chronic disease, and therefore always remains one of the differential values. I would still not keep out autoimmune disorders because they can have a persistent fever, have multi-organ dysfunction, which we have seen in the study. But beyond that, if we have the examination finding, I think it is different. So that I would find respect.
Okay. Thank you, sir. Dr. Viras, proceed.
Yes, sir. Anthropometry in vitals. Child is lying in the bed in supine position with an IV cannula over his right hand. He's comfortable and alert. Temperature was 101 degree Fahrenheit. Auxiliary temperature. Pulse was 112 beats per minute. Regular in rhythm, normal in volume and character. All peripheral pulses well felt equally and bilaterally, and there were no radiofemoral delay. Respiratory rate was 25 cycles per minute. Child was slightly tachypneic. Blood pressure was 114 systolic and 70 millimeters of mercury diastolic. In sitting position in left upper arm, the percentile was less than 95th percentile. Oxygen saturation was 98% on room air in right upper limb. The weight of the child was 29.1 kg, and which fitted in between 10 to 25th percentile on IAP growth charts. Height was around 133 centimeters. Um, BMI was 16.45 kg per meter square. Um, so general examination. Child had pallor. Iterus was noted in bilateral sclera. Pitting pedal edema was present in both the lower limbs below the knee. Periorbital edema was also noted bilaterally. There were no signs of cyanosis, lymphadenopathy, or clubbing. Um, on head-to-toe examination, there was no abnormality detected, and there were no signs of alopecia. Icterus was present in the eyes, no cave ring or cataract was seen. There was no foul smell and oral hygiene was well maintained. Ascitic tapping site was seen on the left lower flank with dressing applied over it. Umbilicus is transversely stretched. Um, Hands and limbs, the child did not have any tremors. There were no pruritic marks or scratch marks over the body. Uh, no apparent nutritional deficiencies that I could notice. No dilated veins over the abdomen. no abdominal stria, and most importantly, there was no rash or eschar that I could find out. On systemic examination, the oral cavity was normal, the hygiene was well maintained. Abdomen looks distended uniformly with visibly full flanks, and umbilicus is transversely stretched and everted in smiling umbilicus. No dilated veins over the abdomen. The dressing was noted at the site of ascitic fluid tapping, and no visible pulsations were seen over the abdomen. All quadrants moved equally with respiration, and there was total edema on inspection. Um, on palpation, the abdomen is distended, girth was 69 centimeter, tenderness was present on the palpation in the right hypochondriac and epigastric region. Abdomen was soft overall. Liver was palpable 4 centimeter below the right costal margin in the mid-clavicular line, which was soft in consistency, rounded borders, smooth surface, and tender. Spleen was palpable 2 centimeters below the left costal margin, soft, smooth surface, non-tender, and splenic notch was felt. External genitalia was suggestive of scrotal edema, but I could feel bilateral testis separately. Um, Percussion and auscultation. On percussion, dull note was felt on percussion in the fourth intercostal space. The liver span was measured using tidal percussion, and liver span was 16 centimeters in mid-clavicular line. Shifting dullness was there, and tympanic note was heard in the umbilical region. On auscultation, vowel sounds were heard normally. There were no bruit or venous hum or rub, and rectal examination was not done.
Just hold
Respiratory.
on. Just hold on.
Yes.
Professor Amdekar, go back to the general examination. Professor Amdekar, please.
So I think all that we know is whenever you talk about pallor, it's 1+, but that means it's not possibly a severe pallor, and we are not really bringing in anemia in our discussion. When you go further on that, yes, but you said abdomen is soft, right?
Yes,
And
sir.
the liver is also soft.
Yes,
Am I
sir.
right? So
Yes, sir.
now, how do you explain that soft liver in spite of the span being big, and also the abdomen soft, but you have an ascites? So don't you think this is discrepancy?
Um, yes, sir. I wrote the abdominal soft because there was no tense ascites that I could feel. Um, that's the only reason why I have mentioned that the abdominal is soft.
Okay, so normally we would not have expected a soft liver or even a soft abdomen on palpation, but well, uh, so now the only positive findings are there is a hepatosplenomegaly, there is an ascites, there is a generalized edema, and there is an icterus. He's not very sick looking at this point of time, and I think that is where we stand. Uh, the other systems are normal, right? Do you have anything in the other systems?
Um, yes, sir. So the air entry was slightly reduced in the right infraaxillary region. Apart from that, the chest was clear and there were no signs of respiratory distress. Apart from that, I do not have any positive findings on my systemic examinations.
So how do you explain that small little sign on the respiratory tract you said? What does it suggest to you?
So mostly because I think there's an enlargement of liver as well. So if there is an upward enlargement of liver, and also I have examined the child, so I thought that it might be because of hepatomegaly only, that the right side of the chest expansion has been affected. Also, I cannot rule out a mild pleural effusion on the right side, but there were no signs of any tracheal deviation or a tracheal shift or mediastinal shift. So yes, sir. So I think two
But
of the
yeah, but come on, somebody was talking. Please, Varinder. The point I was making is that if there is just a little small area infra-axillary on the right side, then infra-axillary, we want to be sure in which interspaces, intercostal spaces we are getting all that. Okay, on the right side, it could be a liver that's giving you a false impression, but we need to be sure about that. But in general, the chest is otherwise clear, and
yes, sir.
so possibly we do not know correctly what is this cause of so small. Maybe if you would have said which intercostal spaces you are getting that, then we could have possibly considered it as just the liver there. But even then, you could have differentiate liver from anything up in the lung or a pleura by asking him to take a deep breath and
Deep
see
breath.
whether the percussion note is changing. Did you do that?
Yes, sir. But I could not appreciate any change
Okay,
in
that's
her.
all right. That's all right. Okay. What about other systems?
So, in other systems, I could not notice any positive, I could not examine any positive finding. Child was conscious and oriented to time, place, and person. There were no visible focal neurological deficits. Tone power was within normal limits. Deep tendon reflexes were present normally across all joints. There were no abnormal or involuntary movements were noticed. Bilateral pupils were mid-dilated and equally reactive to light, and there were no signs of meningeal irritation as well.
Fine. So now we have an issue that we have a liver and spleen and ascites and generalized edema in a child with icterus and nothing major to add on to all that. But the fever is still on now about 2 weeks plus. And now, uh, how do we give a probable uh, provisional diagnosis at the end of all this? Do you stand with saying that it's likely to be an autoimmune disorder, or would you still consider some infection? Well, we have had a good discussion of all pros and cons, and how would you put it up? Then we'll certainly add on that. Anything that we added on after we discussed the history part and we talked about many probabilities and plus and minus, and most of us agreed that it may not be infection. Most of us agreed that it could be immune mediated disorder, but we were vague in saying all this because we could not put our finger into one definite syndrome there, right? So let's see what has been your final diagnosis at the end of that, and how would you justify that? Right,
Yes,
I'm
sir.
sure we all gave several possibilities, so don't worry.
Yes, sir.
Just a minute. Dr. Neelam, your inputs after physical examination.
Okay, so thank you so much. Now, one thing is very clear from the physical examination is that there is a lot of necrosis going on. If it is, he says the liver is tender. So, and it is not very tensed ascites. So I would still keep the and now I want you to tell me a little more about the fever. Are you clear in what you are saying about the fever? You started telling us that it was fever, chills, rigors. Then what happened? Is the fever same high grade since 3 weeks? How is it?
So ma'am, the intensity of fever has gone down significantly. Initially, it
So
was
it
very high grade
started
fever
with
with chills.
initial fever and then it is like a lingering little low grade fever.
Yes, sir. Yes, ma'am. The fever that we encountered here was not above 102 degree Fahrenheit. It was not certainly not high grade,
No, the
and
102 is very high to me.
100
I mean, I
110.
would have just thought
It
if
was,
it is 9900 or is it more?
but
Because if it is that much, I will have to keep HLH also in my mind.
ma'am, the fever was around 100 to 101 degree Fahrenheit is what we encountered during our when the child was
Okay.
admitted.
Right. So one thing is that uh, still keeping a possibility of in infection enteric hepatitis with HLH with the form of is possible, but I would put if I have to think there is pallor, I would think that there is hemolysis. And if there is hemolysis, I would keep two things in mind, which is Wilson's and autoimmune. And that can give that can explain me the pallor, and that can explain me the fever part and the tenderness too. So I would still stick on to these diagnoses, which I thought, because they're keeping Wilson's, keeping autoimmune, keeping infection with enteric or hepatitis with HLH. These would be the three possibilities I would keep.
Dr. Bala. Dr. Bala, you are with us? Okay, proceed, Dr. Viras.
Yes, sir. So, I
And you
just
said there was no CLD signs, am I right?
no, ma'am.
Palmar
Apart from
erythema or
ascites, no, I
you
could no, ma'am.
right. Okay.
So there were no signs suggestive of any chronic liver disease apart from obviously there was some ascites and
Yeah.
splenomegaly, but no other stigmatas. Uh, I think I've made a small mistake that I've given a differential diagnosis. I'm not given a definitive diagnosis as Dr. Ambekar sir has told me. So forgive me for this. A 10-year-old, a 10-month-old male child admitted with complaints of fever, progressive abdominal distension with icterus and vomiting with following findings of hepatosplenomegaly, uh, moderate ascites and icterus, has acute liver parenchymal disease with splenomegaly, with signs suggestive of liver cell failure, with signs of portal hypertension, with maybe a right-sided pleural effusion without any active CNS involvement. Uh, and so my diagnosis on the basis of this summary uh, is mostly towards an infective pathology, more likely, as all my teachers have said, that it looked like a tropical illness, tropical illness like um, leptospirosis or rickettsial disease. Um, and over on the, it seemed as if it was an acute on chronic kind of liver presentation. So the child may have an underlying chronic liver disease, uh, maybe in the form of autoimmune hepatitis or Wilson's disease, and which got exacerbated due to an acute infection.
Viras, what are the signs of portal hypertension in this case? What are the features you found out to think portal hypertension is there?
Yes, sir. Sir, ascites and splenomegaly were the only two signs that I could think of reasons why I did that there were signs of portal hypertension. Hepatomegaly, ascites, and splenomegaly.
Right. Proceed.
Uh, so, do I start with the investigations?
One thing, if I may say here, add here is, with the permission of Dr. Ambekar, sir, portal hypertension in a small child is more of an extrahepatic rather than hepatic. We haven't heard anything about the shrunken liver or a firm sharp margin to suggest a cirrhosis, and therefore a portal hypertension secondary to liver disease. We are looking at an acute injury, still enlarged and tender hepatomegaly. So therefore, portal hypertension, I'm little worried to keep as a diagnosis. I'll rather be more, inclined to think of maybe a Bacchiari, which is going on, wherein you could explain most of these findings.
Thank you, sir. Dr.
So
Viraj, you count
we,
only one or two for infections, not so many. You narrow
Yes, sir.
down because you have done physical examination, right?
Yes, sir. Yes, sir.
You just one or two give one or two infections. That's all.
Yes, sir. Yes. I'm
I
sorry, sir.
think
I
the
gave a different.
post-sinusoidal obstruction like a Budd-Chiari has no reason to have prolonged fever going on for 2 weeks. So acute onset could be a hepatic venous obstruction, a post-sinusoidal typically like a Budd-Chiari, but that fever to begin with for a week or so before any jaundice came in. So acute Budd-Chiari would have come with an acute onset of uh, ascites and hepatomegaly, and then possibly that would have fit in. But that fever possibly doesn't fit in with Budd-Chiari or a venous obstruction. Then same story about the Wilson's. That Wilson's can have a wide variation, but probably not fever for a long time. Then the question is leukemia, lymphoma. No, there is nothing happening beyond the liver involvement and the fever. To that extent, lymphoma is out, and to me, even leukemia is out. So that leaves behind some possibility, as Neelam also said, acute on chronic, but that chronic is not visible in this child unless you say that it's an asymptomatic, say, hepatitis B carrier, and to which added some kind of a liver insult, and it became so-called an acute on chronic, yes. But chronic or symptomatic, Neelam, your view on this, would you be harboring an asymptomatic chronic viral infection?
Sir, very rightly said that it is majority of the time asymptomatic, chronic, but it is not viral in this age, in this era. We don't think of hepatitis B and C. Maybe over the years we have given a vaccination and Hep C is almost so we don't see Hep B and C. If at all we see, we will see an underlying Wilson or autoimmune, which looked like compensated, and suddenly any infection triggers it. But in this patient, this fever, which is 102, which he says, I am finding it very difficult to buy the story that this was Wilson with hemolysis and presenting classically. But this much of fever is very unusual. That is why I kept thinking that it has to be an infection, something which is triggered. And I also agree with Dr. Varinder, in which he was rightly saying there is no dilated veins, no tensitis, and spleen is too, and ascites. So he wants to think more in terms of hepatic inflammation with hypoalbuminemia, with sinusoidal or hepatic vein congestion. He wants to call it like an early portal hypertension. Maybe in that case, I agree, because sometimes when we see the ascitic tap, we find the SARC more than 1.1. And what we used to read and what we used to imagine as clinically, sometimes we don't see the same thing, that it's we do see like this early. But to call it classical portal hypertension, in what Varinder wanted to highlight, he had his own point in that. But to answer to you, we do see, but not hepatitis B or C carrier. We would see it with an underlying Wilson or autoimmune.
Fine. So can we have the investigations now, Viraj?
Yes, sir. Yes, sir. So upon arrival, the child was investigated thoroughly. CBC was.
Just Viraj, 1 minute.
Yes,
As
sir.
Madam says, persistence of fever generally points more towards infection rather than other conditions. Dr. Bala, your inputs briefly.
Can you go to the previous slide, please? Can you go to the previous slide, please? In this, I would change the order of what he has given. In fact, I would remove the term acute infection. This is 3 weeks illness. There is no question of calling this acute anymore.
Yes, sir.
Just put it as infection. And in this, as I said earlier, malaria is absolutely out. Leptospirosis out, rickettsial out. Viral hepatitis, A, extremely unlikely. B, as Neelam said, B, C, de novo in a 10-year-old. I can't think of it. Enteric fever, I would agree, it is very much possible. In fact, enteric fever, I have at least seen 3 or 4 cases presenting with jaundice and high fever. Okay. In fact, most of them have been proven with the bone marrow culture, surprising us. As Neelam said, brucellosis has to be thought of. In this child, enteric fever is not ruled out at all. At all. This can very well be. The only point against this being enteric fever is that there is more of hepatomegaly than splenomegaly. It's the other way. It's more of a splenohepatomegaly in enteric fever. In addition to all this, brucellosis, melioidosis is one diagnosis which cannot be ruled out. The second, of course, will be definitely Wilson's and Wilson's and Wilson's and Wilson's. Of course, Dr. Neelam says fever is unusual, but any chronic hepatitis can cause an inflammatory response and can have fever, but not this sort of high-grade fever. Metabolic disorder other than Wilson's, I'm not going to think of in the presence of fever. The third will not be malignancy, it will be inflammatory disorder. In the inflammatory disorder, I'm putting autoimmune hepatitis in SLE, though both are more common in females. Both are known to have joint manifestations, cutaneous manifestations, hemolytic anemia, etc. But it is not absolutely ruled out. And in the malignancy, other than leukemia, lymphoma, in fact, I wouldn't consider leukemia and lymphoma in this child who doesn't have a single lymph node at all and who doesn't have significant anemia, or thrombocytopenia, or rash, or any metastatic manifestation. But there are 2 things I would have thought of. One is HLH. That should be considered. In fact, I would even put that as second. Next to infection, I would have put that as a possible diagnosis. It can present with fever like this. It can present with hepatomegaly, splenomegaly, hepatomegaly, ascites, etc. High-grade fever, not remitting with antibiotics, and edema can occur. Anything can occur. The only point against HLH is that the age of the child. 10 years, rather unusual for HLH, but it's not unknown. Or it may be a combination of infection-associated HLH. Enteric fever causing HLH, brucellosis, melioidosis causing HLH, EB virus infection causing hepatitis as well as HLH. That's the next possibility. Because one other disease which can bowl all of us, particularly in the younger child, is LCH. LCH. Because even though there is no skin rash, there is no seborrhea, there is no otitis media, Wilson's can definitely fool all of us by causing cholestatic hepatitis. And the skin manifestation, the scalp manifestation may be subtle and can be missed. And for autoimmune hepatitis, yes, it can present like this. It's absolutely not ruled out. And finally, a combination of more than one of this. Wilson's disease triggered or associated with hepatitis A. See, the initial illness might be hepatitis A causing jaundice, with the primary Wilson's chronic hepatitis continuing to progress can explain. We all of us know that hepatitis A and Wilson's disease can be a serious affair. A combination of this. And similarly, a child who's got an autoimmune disorder suffering from an infection from which it doesn't seem to recover, but the primary disease, the autoimmune disease, worsening the whole problem. These are my thoughts at this point of time.
So I think what is interesting is all four of us have said the same thing right from the beginning. All four of us like said enteric, and I said enteric with HLH. That's what I would say.
Yeah.
And we also said, if at all, brucellosis, we did think tuberculosis, brucellosis at that. But as were getting close, all of us thought that if it is Wilson's, it has to be a little bit with hemolysis. That's when you can get fever. And I still say that Wilson itself will not give rise to this fever unless and until the hemolysis was very significant. And two, one of the hint which this student has given us is a tender liver. That again makes us think either there is an infection, or it makes us think either there is an hemolysis or something like necrosis going on, inflammation, autoimmune, Wilson's, all this. So all four of us have been telling the same thing, which is in infections we put two, and Wilson's and autoimmune. This is what we've been thinking so far. And HLH per se, I wouldn't. I would say secondary HLH, like Bala is saying, acute HLH. No, it will be secondary HLH which occurs. And Hep A is the most common etiology which triggers Wilson, which I totally fully endorse. And I wouldn't keep EBV, CMB like this. There is no lymph nodes, nothing the way this child has presented. I wouldn't want to keep that.
Last Neelam, however rare it may be, 10-year-old child, common variable immunodeficiency can present with some unusual infection and fool all of us. Because it doesn't present like this, it's very rare. But one immunodeficiency which can fool pediatricians by presenting at a later age with unusual manifestations like this is common variable immunodeficiency, which is not unknown, which is reported to present even at the age of 20, 30 years in literature, however rare it may be.
I think at the end of all this discussion, what I think we are sure of is one, portal hypertension. You have a liver, spleen, and ascites. Now, it has to be either sinusoidal portal hypertension
Yeah.
or a post-sinusoidal hypertension. Now, we need to club it with the fever for 2 weeks and high fever. So now, which disease starts with only fever and ends up with a portal hypertension? It's
We
a short
forgot the
period
immune
for a portal
system's only
hypertension to
effects.
develop. Therefore, I thought whether we are still, there was a suggestion of a venous obstruction coming, and whether there is some reason for a post-venous post-sinusoidal obstruction coming up in this child. Therefore, there has been a reasonably acute onset of portal hypertension. Normally, portal hypertension is a chronic disorder. So now, question is how to tie up with prolonged fever, and I think we have discussed reasonably all possibilities. Each one of us have given their impression, but none of us are sure whether it can fit in typically one way or another. So I think let's look at what more investigations etiologically have been done on this child. Whereas, do you have any
Whereas,
more
Yes,
investigations? Yes.
yes, sir.
What about cystosomiasis? Do you see in that region? Theoretically, I've talked about it, but I haven't really seen, we talk about it in such scenarios. We do talk about it, though I don't see much.
Um,
okay.
no,
Viraj,
ma'am. Yes, sir.
yes, yes.
Let's see
Yes.
what more tests have you done.
So
No, you
we
can
did
only positive things, only positive for want of time.
okay, sir.
Yeah.
In terms of positive findings, I could see that the serum bilirubin levels were elevated slightly. The total bilirubin was 2.3 and it was direct in nature. SGOT and SGPT levels have also been increased. Apart from that, we can see that serum albumin levels have been on the lower side. It is only 2 grams per deciliter. The CRP is also high, 108 milligrams per deciliter, and the serum procalcitonin levels done were also very high, 68. Um, yes, sir.
There is
We had
anemia. Anemia is there, right?
yes, sir.
Hemoglobin
Anemia is there.
8.7.
Hemoglobin of 8.7 was there. Yes, sir.
Proceed, proceed.
Um, we had sent a
Just
tropical.
one comment on. Please go to the slide. I think here there is some very important clue where you find SGOT nearly 3 times that of SGPT.
So it's a systemic disorder
Yeah.
with
Yes, sir.
secondary involvement of hepatocytes.
Yes, sir. Yes, sir. Yes, sir.
And that's what we started off saying, that a fever and then a week or 8 days later, a liver disease coming up is certainly not a primary liver disease. And I think this is that. Second is that albumin is very good. To that extent, I think we have ruled out a chronic liver disease of any kind. So far we know that much. Again, anemia is not very severe and CRP is very high, procalcitonin. So we have still a persistence of an inflammatory disorder with systemic disorder primarily affecting the liver secondary to that primary illness. Now we don't know yet what primary illness has been, but we said less likely infection, but we still want to get more and more details. So far, the whatever has been
What is
tested have been
interesting
negative.
is your
Yeah.
sir globulin is pretty high, so that is usually seen more in autoimmune. Such high globulin, 3.4. That is one point which is hitting there. But the other interesting point is in autoimmune you should have PT more than OT. But in this case, OT is much than PT. But if you say OT more than PT Wilson's, you will have low alkaline phosphatase, which this child doesn't have. So that point is in this. I think the globulin high is something which is drawing my attention, and still keeping the you have to tell us the peripheral smear, what it is, the eosinophils, what it is, and the peripheral smear, these two you have to tell us.
Ma'am, the peripheral smear was consistent with some microcytosis and hypochromia, but apart from that, there were no positive findings, no abnormal
Okay,
cells were
so no
seen.
hemolysis, no
No,
cells. Okay.
no, ma'am, no, ma'am.
Neelam, have you seen leishmaniasis presenting like this? Neelam.
Sir, I saw only one case when I was in Gangaram 2004 or 5. After that, I have not seen. And I think, like you said, everybody would have got antibiotic which would have treated. I think maybe that, I don't know. I've not seen any leishmaniasis in my life, though people from Bihar claim that they've seen. I've never seen.
Because it can notoriously present like this and also present with HLH. That's what they
No,
say. I have not seen.
that's why I want to know eosinophil. What is this eosinophil? Can you tell me what is your eosinophil?
Uh,
Is it zero
I'm
or
very
what?
sorry.
You
Ma'am,
have
I'm very sorry. I
51.9? Huh?
don't have those reports at the moment or for
Okay.
eosinophils particularly. I'm very sorry, ma'am. Uh, I think it was normal because
Can't be
most of
normal. It can't be. Chalo, anyway, go proceed. In this, the only thing is your low albumin, but a globulin very high.
yes, ma'am. So we had sent a tropical panel which consisted for PCR for rickettsia,
Okay,
for
next.
yes, blood ammonium levels were normal. Hepatitis panel was sent and which was also negative and non-reactive. We had done a USG for abdomen pelvis and which was suggestive of hepatomegaly with coarse hepatic echo texture, mild to moderate ascites, minimal non-tappable right-sided pleural effusion, mild splenomegaly, and gallbladder wall edema. This was the X-ray that we had done here.
No, interpret it.
Um, Sir, in the X-ray, we can see that. Okay, sir.
No, briefly, only positive finding.
Yes, sir. I could see that the right-sided lung capacity is slightly reduced. The number of rib spaces are decreased, but there is no costophrenic blunting, which might be suggestive of ascites. Apart from that, the liver seems to be pushed up. Yes, sir.
Not pushed up, enlarged. Okay,
Enlarged. Yes, sir.
right. Next.
Cytic fluid analysis was done. Total cells were 212 cells per cubic millimeter, of which 55% were polymorphs, lymphocytes were 0%, macrophages were 45%. Ascitic fluid protein and was 2.28, and ascitic fluid sugar was 101. LDH was 332, and ADA was 21.1. I failed to mention the ascitic fluid albumin level here. We had calculated the SAG levels, which were about above 1.1.
Tag was not
Which I
available.
was telling you that normally we see this surprise, but we said, and that's what I was telling to Varinder that we do see.
Uh, We had also done some workup for Wilson's disease. An ophthalmological review was done, which was normal. Serum ceruloplasmin levels were also normal, 37. 24-hour urinary copper levels we had done, but they were slightly higher. Um, an autoimmune liver panel was sent after taking hepatology opinion, which came back positive for anti-smooth muscle antibody. The LKM1, ANA, and AMA panel was negative. The total IgG levels were also raised. A 2D echo was done, which was suggestive of no abnormality. An upper GI endoscopy was also planned in view of suspicion for portal hypertension and therefore varices, but there were no signs of any active varices. There were only some mild duodenal edema which was noted. A CT was also planned, and which was suggestive of hepatosplenomegaly with mild periportal edema. There was no evidence of intrahepatic biliary IHBR dilatation. Moderate ascites was there, and mild right pleural effusion was there. Also, I failed to add that a Doppler was also done to look for any to look for the portal venous flow, which was also normal, reported normal. Uh,
Gene expert of the acidic fluid.
uh, Sir, we
Not
had
done.
not sent,
Not
not
done.
done.
Not.
Um, an infectious disease opinion was also taken because the CRP and the procalcitonin levels were too high to ignore. Uh, so a leptospira IgM antibody came back positive, surprisingly. And based on the above findings, the child was advised from the hepatology side to consider for liver biopsy. And yes, sir. On the day 4 of admission, as we have seen that the serum bilirubin levels started decreasing, the SGPT, SGOT levels also started declining. The child had received albumin transfusion, so the serum albumin levels are up. Uh, yes, sir. And apart from that, the hemoglobin was 8 grams per deciliter on day 4 of admission with normal total leukocytic counts and normal platelet levels. Uh, the child had received broad spectrum antibiotics. It was started with
Just hold on,
piperacillin.
Vilas.
Yes, sir.
The inputs from Dr. Neelam, Dr.
You have missed so many things, my God. How come you didn't do any HLH? Nothing you did. The ferritin, HLH, interleukin, IL, lipid, triglyceride, nothing. So this can be a classic. What I'm saying that enteric with HLH. Why not? Because you gave antibiotics. Day 4 of the illness, things are improving. His OT was more. Which was again typically seen. I wouldn't do liver biopsy at all. Don't listen to this person and go ahead for a liver biopsy now. Just wait and see a little more. You didn't even send Brucella PCR. You didn't send an
Uh,
HLA profile.
Ma'am, we had sent a tropical fever panel which included the Brucella PCR, and
Okay.
we had not suspected HLH. So
No, but
the
that is the first thing you should suspect than anything. And that was the opening statement we gave enteric with HLH, enteric with HLH. Simple enteric will never give rise to give. What's your INR?
uh, ma'am, the INR was normal. Actually, that's why I'm not mentioning the report.
It cannot be. Your INR, you've not mentioned fibrinogen, NK cells, interleukin, ferritin, nothing. So that's why the child is responding to your antibiotics. Don't do biopsy now. Wait a little more.
Yes, ma'am.
Dr. Amdekar, your take on investigations.
I think largely we have two things positive here, some autoimmune positive and even leptospiroid. Now, to my mind, when you get 2, 3 diseases present on investigation, one has to be really looking at carefully whether at least not all but few of them could be false positive. And therefore, IgM is known to be false positive, and it's not that IgM means only a recent infection. After all, this child has a small time illness, so one may accept IgM because it's only a 2 weeks illness. But the story did not fit in perfectly. We did say that leptospira was an immune-mediated complication, and therefore, finally, it looks like that this child has had some immune-mediated complication out of something different that started, which was extra hepatic, and then liver got involved. And further progress of a liver disease was very, very fast, and therefore something that brought in an acute liver cell disease over something that was extra hepatic, and we have not yet correctly put it out. Could it be leptospira? I said yes, maybe. We have a discussion on all that. Could it be some immune mediated disorder? When we mean immune mediated, we are very vague on it. I feel autoimmune hepatitis by itself should not have been done that with fever going on for a long time and a jaundice coming up much later. So that is my view. And I think we are left with a guesswork as of now. Uh, any comment from Bala, Neelam, most welcome.
Sir, we don't do leptospira IgM antibody at all in our center.
It
That's
is
right.
80
That's
to
right.
We have stopped
90%.
doing. We have
Mm.
we have
Correct.
stopped doing it.
So they
It
are
can
not
remain
reliable at
positive for
all.
yeah.
Yeah.
It can
So
remain
all that
positive
you
for
have had, some
in fact,
antibodies, okay, are positive. That is all that we have. and it is a systemic disorder. That's another definite thing. I think this is all that we can think.
What is the antibody titer? You did immunofluorescence SMA or what? SMA,
Yes.
you said positive. What is immunofluorescence?
Ma'am, 1:80 was the antibody titer.
Right. And ANA, LKM, SLA?
They were below they were negative on the AIH panel. I specifically don't remember the titer levels
Right.
for
So,
LCM.
and it is only day 4 you have, or you have any further follow-up? Anything more follow?
Ma'am, the child was on the, I think on the 7th or 8th day, the child was discharged from the hospital after he improved, and
Which
he
day?
was advised. Yes, ma'am.
How many days
Yes, ma'am.
back?
So this case I had taken in, ma'am, 4 months back.
So did you
So
follow up? Did you call and
yes,
ask
ma'am.
for
Yes,
happened?
ma'am. Yes, ma'am. The child had come on follow-up, and the child, the ascites had completely gone. Um, the icterus had also come down, and the child was doing well. Currently, the child is doing well, and there was no liver biopsy done after review. After
That's what
coming
I
to the
said.
hospital follow-up,
So it
liver
was
biopsy was not done.
enteric with HLH, and that's why you treated it, improved. We see this way, and never we should jump in to do biopsy so early because it will not tell you anything at that time. And the hint which you gave clinically was a tender liver. That was very useful. And the second thing which you had said was a liver with a spleen and a fever, which I kept saying it is very, very unusual for fever in autoimmune or Wilson per se. They can be 90, but somebody having 102, 103, put your bets on HLH. And if you would have just done some ferritin, some triglyceride, we would have been happy and excited right now. And I would still insist you to go back to your hematologist, though they would have thrown it. See the peripheral smear carefully if you can see something in that still. The
Yes, ma'am.
report at least
Yes, ma'am.
you look into. To me, this is classical. That's why I said don't do this, because SMA is one of the most common false positive thing that you would have seen in that.
Yes, ma'am.
Interesting. Thank you so much. It was lovely to see how Dr. Amdekar segregates that history, the way he takes. We people have so much to learn with him.
I think we had a good discussion, so let's call it off now. Good night to everyone.
Good night, sir. Good night. Good night to everyone.
Right.
Thank you.
Good
Thank you,
night.
Dr. Neelam, for participating. Thanks, Professor Amdekar, for enlightening us. And thank Dr. Bala and Dr. Varinder for the input. And Dr. Viraj, you have presented nicely. And good night, everyone. Thank
Thank you.
Thank you,
Good
sir.
night.
Good night.
Thank you. Good night, sir.
Good night, all of you. Very good.
Good
Yes, sir.
night.
Thank you.
Thank you. Thank you. We all learned how ignorant we are, even at the end of all that. So that's a take home message. And we are always looking for improving on ourselves. But it was a nice discussion. And I'm so happy that so many of them interacted and joined the discussion. Thank you very much, Dr. Ramakrishna, for giving us this opportunity. And we enjoyed it. Thank you very much. Viraj,
So,
thank you very much for having
sir.
presented a case, and you did a good job. Good night, sir.
Good night.
Thank you very much, sir, for your kind words.
Thank you, Viraj. Good.
Thank you.
Good.
Thank you.